Thank you for that introduction. And so now we'll get started on the talk. So our objectives for today are to discuss some of the pertinent background information regarding the International Organization for Standardization, otherwise known as ISO standards for enteral systems. We'll talk about some of the unique challenges in neonatal enteral device safety in general. And then we'll review the Infit Syringe and its accessory designs to highlight some potential dosing and accuracy risks. And then we'll examine some of the available literature regarding dosing accuracy of the Infit Syringe product line. So as some background about misconnections, we know that device misconnections can lead to devastating consequences if and when they occur. Nearly 40% of these are attributed to enteral tubing and enteral IV mismatches. We do know that if enteral feeds are infused intravenously, this can result in significant patient morbidity and mortality. It can have overall devastating effects, and so it's something that we work hard to try to prevent. Focus has been placed over the last several years on developing methods to prevent inadvertent misconnections. The big focus of this has been to make design differences, because we know that if we can make it impossible or close to impossible for people to put things in spaces where they're not supposed to, that's going to be better and more effective than just education and other factors. ISO created small bore connection standards for enteral device systems. 80369, we'll talk a little bit more later about what each of those standards represent. But GETSA, or the Global Enteral Device Supplier Association, was formed to answer the call for the new device designs. So some of those important ISO standards, we have 20695. So this specifically deals with the requirements for all enteral feeding devices. And this includes syringes, tubes, lines. It incorporates the small bore connector requirements that you'll see in 80369-1 and 3. So 80369-1 are just the general requirements for small bore connectors that are utilized to deliver liquids or gases within the patient care setting. The goal of 80369-1 is to increase patient safety and reduce the risk of misconnections between unrelated delivery systems. So as you can see on the graphic, 80369 has several different caveats and crosses everywhere from respiratory devices all the way through neuraxial, as well as enteral, which is 80369-3. And this is the standard that specifically applies only to the enteral system. So we know that there's been a push from several safety groups within the US to start to adopt practices and technology/devices that help to prevent these misconnections. The ISMP Targeted Medication Safety Best Practices for Hospitals for 2020-2021 in their Best Practice 4 state that we must ensure all oral liquid medications that are not available in unit dose packaging are dispensed from the pharmacy in oral or enteral syringes that meet ISO 80369. They specifically comment that oral and ISO compliant syringe tips are designed to be incompatible with vascular lines so that they cannot be inadvertently attached. And I want to point out that this rule does say ISO compliant, and we'll talk a little bit more about why that's important later. So GETSA has formed some proposed Infit conversion dates. Originally, this was set a little bit earlier, but as we all know, the world has been all things COVID over the past year. And so these dates have been pushed back a bit. But now their first phase approach is in July 2021. They will start phasing out legacy tubes and adapters, and these will no longer be manufactured. So legacy tubes refers to what most of us are used to in today's healthcare setting in the United States, which is you have a female tube that connects to a male slip tip oral syringe. The second phase of this conversion will occur in January 2022, where the transition sets and adapters that are sold separately from other devices that are non-Infit will no longer be manufactured. So there are some important questions for us to consider at this point. So are these devices safe and accurate for all patients? If not, are there any patient populations that may be more vulnerable to potential harm with these devices? And if we cannot use the male legacy device line, and if Infit isn't the best fit for certain patient populations, what alternative options do we have available? So at this point, I want to talk about some neonatal considerations of this patient population in general. It's important for people who work or who deal in any manner with the neonatal population that we are advocates for this vulnerable patient population. I want to point out that these babies were already born into the world too early. They were not meant to be here at the time and place at which many of them who are born prematurely come into the world. The tragic part of that is that we are often forcing these babies to fit into our existing standards for medications and therapies and devices. Instead of accommodating those to them, we're forcing them to accommodate what we have. And so it's important that we consider these population-specific factors and that we try to accommodate them with devices and designs and medications that will help minimize that risk versus benefit profile for this very high-risk, vulnerable population. So when we're looking specifically at neonatal enteral safety considerations, we obviously want to prevent misconnections. Putting an enteral feed into an IV space in a neonate would almost certainly result in catastrophic outcomes. We also need to think about the specifics of medication administration and where there may be safety risks there. So with medications in this population, we always want to ensure dosing accuracy to the highest degree possible. We want to determine what our threshold of acceptable dosing variance is. Surprisingly, there's not a ton in the literature that describes what we should feel comfortable giving above or below what we intend to give with each and every dose. We also have to think about dispense volumes. So a lot of times we're having to extrapolate neonatal dosing formulations from adult formulations. And so we're using things that are often high concentrated, or we're using things that must be compounded. So there's room for potential error with compounding issues. We also have to think about monitoring of side effects, and we'll get a little bit more into that later as well, but it's often tricky in this population because they can't tell you if something hurts or feels bad. We're having to rely on what we know about these babies and what we think could be going on. Another risk of potential concern in this population that may not be as big of an issue in other populations is enteral tubing contamination. So we'll talk again more about this later, but we have some data showing that there are real harms and risks potentially with enteral tubing contamination with our legacy lines. And so what does this impact have when we're looking at a new design? I just want to point out in general that medication safety in neonates is of high concern. Neonates are particularly vulnerable to medication errors. Up to 77.9 per 100 medication orders in the NICU has some sort of error. And the most common are prescribing and administration errors followed by dosing errors. And while things like computerized physician order entry have solved many of the old school issues that we think of where the doctor would write the order and you would have to turn the order a couple of different directions trying to decipher what was being ordered, we still have issues with medication safety and ordering. Device-related errors are not well described in the literature, but we do know that liquid formulations are often more prone to error than other formulations. And it has been implicated as a source of error in families of pediatric patients, particularly those with low health literacy or those that don't speak English as a native language. One of the important pieces of medication safety practices is trying to make things less complex. So we know that complexity is a major cause of medication errors, and the more complex a process or a device is, you're going to have more variations in practice. There's plenty of opportunities for error with each and every step, and that it increases overall risk of patient harm. We know that reducing complexity is key to improving safety and productivity, and we need to embrace standards of simplification, standardization, automation, and integrate them into every process that we have. And remember that every step in a process is an opportunity for error. So I just want to touch briefly on our dosing targets for variants. So we know that there are no specific oral device performance standards. So when we traditionally think about how much plus or minus should be in a syringe at any intended dose, we think about IV syringe performance, which is plus or minus 5%. We know that with the Infit industry sponsored testing that we'll talk a little bit more about in a few slides, the amount utilized was plus or minus 10%. So as I alluded to earlier, there are no standards within the clinical community for acceptable dosing variants, but at least one paper has been published in pediatric physicians and pharmacists where they were polled how they would feel their thresholds for what they feel comfortable for rounding tolerance and dosing variance in medications. These range anywhere from 0 to 15%. But in those medications where we're trying to avoid toxicity or control the intended and unintended effects of the medication, this acceptable variance falls somewhere between plus or minus 5 and plus or minus 10%, which aligns with what we see again with the IV syringe standards. So I hear often, does enteral accuracy really matter? We know that there are a lot of factors that go into how much drug the baby or the patient is exposed to after taking it enterally, and that it's a different space than when we think about intravenous administration and medications that are going directly into the bloodstream. So I have listed for you here some examples of medications where having a 20% variability, which we'll talk a little bit more when we talk about the performance of the standard Infit syringe, but where these 20% variabilities can and do make a difference. So moving kind of down the left side of the slide, you can see we have medications like rejection medications for patients who may be transplant recipients. This is something where if you have a baby who's fought so hard to get their liver transplant or their lung transplant, the last thing anyone wants is to have a rejection or a toxicity because we've inadvertently under or overdosed what we were intending to give. Another hot topic is the opioid crisis and what this looks like with neonatal opioid withdrawal syndrome. There's a big push from the AAP and other organizations to really try to hone in on how best to treat these patients. The two most common medications used in the United States are morphine and methadone. And so when we look at just slight variations in standard concentrations, slight variations in dosing with these agents can lead to profound under or overdosing, which can lead to either the baby having increased withdrawal symptoms or potentially having respiratory depression and other significant decompensations. Then moving down further towards the bottom of the list, we have different cardiac medications like digoxin and enalapril. I have some examples later about digoxin and what the impact of variable dosing can mean with the syringe and device accuracy with that. But then we also have our HIV medications like zidovudine and lamivudine, and these are commonly used in neonates who are born to HIV positive mothers to help prevent transmission. So we've done a great job in the last several years of getting transmission rates from mom to baby incredibly low. But one of the backbones of this is accurate dosing of our HIV medications in the baby so that we know that we are preventing them from having any residual risk of developing HIV themselves. So dispense volumes are a big deal in the neonatal population. And as I've already alluded to, liquid formulation availability is often limited. So a lot of times we don't have commercial preparations available for medications we need to give, or we have to compound formulations, as I said before, which is a potential risk of error if things are not compounded correctly. There's also a lack of standardization of different compounded formulations. So there have been pushes by organizations like ISMP and ASHP to try to get hospitals that have liquid medications for pediatrics standardized with the same concentrations to have less risk when transferring from facility to facility or home to facility. But this is still a work in progress. And oftentimes many of these recommendations don't work for our smallest patients. The concentrations that are available are often intended for larger doses or older patients. So you sometimes have the problem where doses and volumes are too small to measure, or you're getting down to these 0.03, 0.04 ml doses. And we have to consider, is that accurate? Are we actually able to deliver that? Are we causing potentially more harm? So a lot of times people will make the suggestion, well, why don't you just dilute it and give more volume? And so this is also not without risk, because when we think about the amount of volume going into a low birth weight infant, so for the example here, a 0.5 kilo baby, you can see that their feeding volume may be as low as 0.6 milliliters every 3 hours. So if you were to give a dose of medication that was 0.5, 1, or 2 milliliters, you're potentially doubling their intake for that feeding volume or tripling or quadrupling. And this can lead to risks like necrotizing enterocolitis and other potential harmful outcomes in that preterm gut. One of the biggest concerns with dosing and accuracy in this population is how do we monitor for it and how do we diagnose it? It's incredibly difficult to diagnose in nonverbal patients. Symptoms of toxicity in these kids may be inadequate or just difficult and subtle to determine. There's often conflicting clinical data, and oftentimes we are making diagnosis of exclusions. So say a baby's getting caffeine for apnea of prematurity, we're inadvertently giving too little, and they end up having breakthrough apneas and bradycardia. This baby may then get an entire workup for infection, for necrotizing enterocolitis, for other things, when in reality, it's that the caffeine dose has been inadequate. And so oftentimes we're just figuring that out by excluding everything else that the baby potentially could have. There are incredible differences in developmental pharmacology in this population that lead to unexpected clinical responses and toxicity. So one of the exciting things about being a pharmacist in the NICU is that it's almost like having a living pharmacokinetic pharmacodynamic lab, because you have these babies at the threshold of viability who have not had adequate descriptions of what their response to medication should be. And that baby at day of life 1 will be very different than that baby on day of life 30, 40, or 50. And each baby is going to respond very differently. And so it makes it incredibly difficult to determine the specifics of toxicity and how to monitor for that in this population. Of course, if we have the availability of serum monitoring that we can use for things like digoxin and caffeine, that makes it easier to determine if we're having an unexpected serum concentration from dosing variants. But this can lead to unnecessary blood draws and painful procedures, and not all medications that can cause toxicity have an associated laboratory assessment. So this isn't an option for many of the medications that these babies may be exposed to. The biggest recommendation I have for this is that we must have clear communication of the risks and educate our staff for when they need to be looking out for potential sources of toxicity because of dosing inaccuracy. So some of our current neonatal syringe options, enteral syringe options, are listed for you on the slide here. So we have the male slip tip, which you'll see is often referred to as the legacy syringe. We have the Infit syringe, and then we have the NutriSafe 2. And for the rest of the talk, we'll talk through some of the specifics of performance and such of each of these devices. So some background on the Infit syringe in general. This is a female syringe system. It was endorsed by GEDSA as their solution for ISO 80369-3. The difference with this is that it reverses the orientation from a male oral syringe, and it's now a female enteral syringe. Originally, this was designed to deliver enteral formula. So it's important to keep this in mind as you're thinking through the performance data. Does it matter as much if 0.2 mLs of formula is given inadvertently or not given? Maybe not so much, but when we're thinking about the impact of that on medication administration, it becomes a very different conversation. Originally, the Infit syringe was intended only for enteral administration, but it has now gained oral application approval as well. And so that's important to note that this syringe is approved by the FDA for both enteral and oral use. This change in design has some concerns that many people have brought up since its inception. So the syringe tip itself is a dosing risk. So if you look at the graphics to the right, you can see that that female syringe tip holds about 0.2 mLs of potential overfill. There's also a risk from the new tubing tip, which is a male tubing tip instead of the female, as people have been used to seeing in the United States. So the tubing tip provides potentially dosing and contamination risk, and we'll get a little bit more into each of those factors now. So a recent article published looked at Infit cleaning procedures, and they looked at about 120 tests in each arm. They had a diligent cleaning regimen and then a less diligent cleaning regimen. And I just want to point out, if you look at the table 1 diligent cleaning regimen, there's upwards of 17 steps all over the first few are gathering your supplies and performing hand hygiene. But even the less diligent has up to 9 steps. And so this is getting into that piece we talked about with complexity and leading to potential for variability in practices. So the interventions in this study were looking at a chocolate flavored enteral formula that was visible to the eye, and Dazo, which is an environmental gel that's only visible with UV light. And so they treated the tubing with each of these different types of interventions, and then assigned nurses to one of the cleaning regimens. So they evaluated with a Likert scale of 0 to 2, 0 being there was not felt to be any residue, 1, some residue, and 2, significant residue. The nurses who cleaned their tubes then evaluated their own cleaning process. And then they brought in independent investigators that were blinded to the cleaning procedure and asked them to evaluate the tubing tips at the end of the cleaning procedure. So the results are listed for you here. And if you look, even the diligent, which is 114 samples, even the diligent group had about 70% of their tubes contained residue. The less diligent group overall, almost 87% of their tests contained residue. It was worse with the Dazo group because it wasn't visible as compared to the chocolate formula. So with the chocolate formula, only about half of the tubing was considered to have residue after cleaning in the diligent group versus about 80% in the less diligent group. Of note, the nursing evaluation tended to find the tubes to be cleaner than the blinded investigators did. So that's certainly something of concern, that the caregiver's perception of the cleaning process did a markedly better job than what the unblinded investigators determined it to be. The overall effectiveness of the cleaning procedures is a little bit questionable if overall you're still having 70% of your tubes appear to have residue. And while we can't rule out the clinical implication of contamination with the Infit tubing, we certainly can't say that there are no risks. And we know from looking at the female tubing studies that have previously been done in the neonatal population, enteral feeding tube contamination happens in many of the tubes and can quickly lead to bacterial colonization. This can lead to feeding intolerance, risk of necrotizing enterocolitis. And we also must be concerned that there may be boluses of organisms, pathogenic organisms, particularly each time the tube is accessed. So when we're thinking about that in terms of the neonatal population, many of them are fed every 3 hours. So you may be bolusing enteric organisms every 3 hours, 8 times a day. So moving into the dosing risks associated with the standard female Infit syringe tip. So ISMP issued a dose accuracy warning in 2015. The low volume, they found that the low volume medications were vulnerable to clinically significant under and over dosages. And at that time, proposed several workarounds without addressing the actual design flaw. And what I mean by low volume is those doses that are 2 mLs or less. And the reason for that is that that tube tip contains, again, 0.2 mLs of drug. So if your dose is 2 mLs or less, that 0.2 of potential drug that could be displaced and given or accidentally not given adds up to 10% or greater of dosing variance. And so that's, again, where that 10% dosing variance number starts to come into play. In 2015, there was a multidisciplinary meeting at CHOP that had representation from many different groups representing pharmacy, nursing, nutrition, et cetera. The clinical input was that there were more than 80 medications that have liquid doses and volumes less than 2 mLs a day. And this was, again, from the practitioners at CHOP. For them, they had about 1,200 doses each day, which adds up to nearly 500,000 doses per year that are coming out of their pharmacy that are potentially at risk of over and under dosaging. So if we're looking at an example patient of 1 kilo getting digoxin, if our intended dose is 5 micrograms, our intended volume is 0.1 mLs. If we inadvertently gave the extra 0.2, our actual dose would be 15 micrograms. And if we inadvertently kept the syringe tip full of medication instead of administering it, the patient would have gotten no medication at all. So we know from these meetings that the standard female syringe tip is not safe for low volume medication doses. So next came the Infit syringe with the low dose tip feature. So in 2016, there was an ISMP update that showed that the tip was developed to address an industry-wide problem concerning the Infit syringe dead space and the concerns of dosing accuracy with these small volume medications. So over on the right, you can see what the low dose tip feature looks like. And this created areas of new concern. So there was the creation of the moat, which is the area between the male lumen and the outer ring. And you can see that the moat is a fairly large, bulky area and space on that end of the syringe tip. It also brought about oral adapters. So with getting oral application approval as well, this syringe was too big and bulky, and there was fear that it would cause damage to the oral mucosa of neonates. So those some different oral adapters have been introduced. So looking at dosing implications of the Infit syringe, the low-dose tip doing fluid computational analysis showed that it can displace up to 0.12 ml of drug volume when utilizing the syringe and enteral tubing. So we went from 0.2 mLs to 0.12 mLs with the standard syringe to the low-dose tip. And so this is still highly concerning for ability to cause dosing inaccuracy. So I would argue that we didn't actually fix the dosing inaccuracy problem with bringing about the low-dose tip. So we spoke a little bit earlier about the NutriSafe 2 device. We know that this is a lockable system that's incompatible with other Lure devices and other small bore connectors. It is ISO 80369-1 compliant. It has been designed to minimize the dead space at the end of the syringe and within the tubing itself to reduce dosing inaccuracy. And again, that moat and hub is small enough that it prevents the need or requirement for cleaning procedures that we see with the Infit tubing. This syringe was specifically designed for neonates and has been in use since 2005. When we look at the fluid computational analysis of the NutriSafe 2, we find that it greatly decreases the potential volume displacement by about 4-fold. So taking it down to about 0.02 mLs versus the 0.2 and the 0.12 that we see with the Infit and Infit low-dose tip. So moving into the actual performance accuracy of the Infit syringe, we know that the standard syringe has an incredibly widespread. And if you look at the dosing variance in the graphic here, we have outwards of almost -30 to upwards of +45% of intended dose. So looking at how that performed against the male tip, and then the GETSA-sponsored analysis of the Infit, that standard syringe clearly does not perform well for accuracy and precision of dosing. Some critiques of this analysis: they only tested 1 ml syringes. They did not evaluate any of the oral adapters, and we don't have any information regarding the methodology of how they studied each of the performance assessments. So in my previous institution, we were talking about converting to Infit, and we were concerned about the lack of peer-reviewed literature documenting the performance of these syringes and the available oral adapters. We were also concerned that there was a lack of published male legacy device performance, because it's hard to know how to compare one to another if you don't know what your performance is for your male syringe. So we decided to study it ourselves in the pharmacology lab and establish some baseline performance for the male oral and Infit syringes. We also wanted to determine the accuracy specifically of the Infit low-dose tip system with its adapters, and then clarify if the dosing accuracy of the low-dose tip was impacted by the route of administration. We have all of the different syringe sizes and testing conditions listed for you here. Of note, we did study low and high volume syringe capacity. So we know that the lower syringe capacity or lower volumes of the syringe, accuracy tends to be a little bit more compromised. So we wanted to characterize what that looks like for each of these syringes. We followed the FDA approved instructions for use for each of the syringes, and we tested both children's Dimetap as well as chewable aspirin tablets crushed and mixed with water. We were looking at assessing dosing accuracy by dosing variance. So we were looking at the actual dose that would have been delivered versus the intended dose. And we considered anything greater than 10% variance to be unacceptable. Again, we tested across a variety of conditions, such as a bulk bottle, a medication cup, and crushed tablets. So when we're looking at the performance of the low dose tip, I want to just highlight, if you look at the mean dosing variance for the low-dose tip and the male syringe, it's around 4% and around 8%. So that looks decent until you look at the spread that we see with the low-dose tip. And what we found is that the overall dosing variance may fall within 10% for both of these devices. The actual variance and the amount that fall outside of a tight range with the low-dose tip was incredibly high. And this is another graphic to show you what that looked like. So the GEDSA-sponsored data appeared to show the low-dose tip performed very well on the right, very tight around that plus or minus 5%. And what we actually found was a much wider spread and a high likelihood of both under and overdosing. This shows you what we found for our male syringe performance. So we found that most of these fell within plus or minus 5%, with a few going out to plus or minus 10%, whereas the Deacon et al. Found a wider variability and less consistency within the male syringes. So when we're looking at dosing accuracy by size, overall, about a fifth, 1 out of every 5 syringes or doses tested fell outside of a 10% dosing variance. And when we broke that down by the low dose tip, and particularly the 0.5 ml and the 1 ml syringes, we saw that upwards of 40% of the doses for the 0.5 ml Infit syringe fell outside of an acceptable dosing variance, as compared to about 14% of the male syringes. When we're looking at dosing accuracy by intended volume, we see that the lower the intended volume, so getting down to say 0.02 mLs in a 1 ml syringe, that the lower the intended volume, the higher the proportion of tests that fell out of range. And this is showing you both plus or minus 5 and plus or minus 10%. And so what we saw with this is that really all of the syringes performed poorly, both male and Infit. And so there's certainly room to improve across the board when we're looking at these lower syringes at higher dosages. This slide is just to point out the differences in enteral versus oral dosing variants. So again, the low-dose tip Infit system was originally designed for enteral administration, and we actually found that the enteral route had a little bit more variability even than the oral route. And even though the oral route had overall less variability, there were a significant portion of tests that still fell outside of dosing variance limits. So summarizing what we have from the literature, the Infit low-dose tip syringes have increased dosing and accuracy compared to male slip tip legacy syringes. Again, 1 out of every 5 displayed a dosing variance greater than 10%, which is potentially clinically significant. Smaller syringes and lower volumes are associated with higher rates of dosing accuracy across both syringe designs, but 40 to 80% of the low-dose tip doses with these conditions fell outside of the acceptable range. An enteral administration of the low-dose tip, using the low-dose tip may actually be a little more vulnerable to dosing and accuracy than the oral administration practices. So now we have to ask ourselves, what are our options for ISO 80369 compliant enteral devices? So really our 2 main ones at this point are the Infit standard female syringe and the NutriSafe 2. And then how should health systems address dosing accuracy considerations in neonatal patients? So it's important to note that the ISO 20695 group actually determined that the design of the low-dose tip syringe cannot ensure by itself dosing accuracy, and that we needed to provide user information and education to accompany the device about the potential for dosing and accuracy. The low-dose tip syringe has actually been removed from the normative requirements and is only included in an informational annex to show what the dimensions are to worldwide manufacturers. It's no longer considered a low-dose tip, but is designated as an alternative tip for an enteral syringe. So essentially what that means is that the low-dose tip feature is not 80369-3 compliant. Vigon has been involved in ISO committees extensively, so they have been an expert member in the 80369 working group. They've been involved since 1997. They actually have, again, designed this syringe around the neonatal population, which has been identified as a high-risk population. They've also been an expert member in the 20695 working group. And from its beginning in 2014, Vigon has participated to the creation of the standard and has brought its technical expertise to the group. The low-dose tip syringes inclusion was proposed and appraised, and it was thus found to be excluded from the normative requirements again in June of 2018. So looking at future directions, I think we really need open and transparent communication of potential risks and the safest options between our industry and clinical communities. We need active surveillance of high-risk patients and high-risk medications. And then I think this is an opportunity for standardization improvement in oral formulations utilized in the neonatal population, as well as potentially a way to look at how we can improve the performance accuracy of these smallest syringes with our tiny doses. So for some key takeaway points, the male slip tip and compatible tubing availability is being phased out. More so the slip tip tubing compatibility is being phased out by the enteral device suppliers in the US. The Infit does not address the specific needs of neonatal patients. We know that the syringe tip syringes have a known issue with dosing accuracy. This has been acknowledged both by industry as well as many of our safety groups like ISMP. The low dose tip feature is not 80369 compliant. And so if you were looking in your healthcare system to integrate ISO 80369-3 or -1 compliant devices, this is not one. The enteral syringe standards acknowledge the failure of the LDT to the low dose tip to reliably deliver accurate doses. And so I think if the standard is telling us this is a problem, we need to listen and hold ourselves accountable to that. And then we see that the tube cleaning protocols appear to yield low overall results at clearing residue, and the clinical significance should definitely be followed up with other studies to determine if there's risk there. And then lastly, the NutriSafe 2 was designed specifically for neonatal patients. It minimizes the risk of drug displacement. It's compliant with 80369, and there's no tube cleaning protocol required.